barbecue is a good thing to have. Everybody is really enjoying themselves. Look at the agenda. Any questions about the agenda, additions or corrections? If not, it will stand as presented. And do I have a motion to that effect?
So moved.
So moved. Second?
Second.
Moved and second. All those in favor say aye.
Aye.
Same sign? No. Thank you. Now we look at the board minutes. We have seen the board minutes been presented to us. Anybody have any questions, additions, or subtractions to the board minutes? If not, do I hear a motion that we accept them as presented?
So moved.
So moved. Second?
Second.
Moved and second. All those in favor say aye.
Aye.
So be it. Jim, since you look like you're ready to go, we'll go ahead and let you tell us about the finances. Thank you.
Thank you. Good afternoon. In your packet or on your iPad or on the screen here, you'll see the financials for the Department of Social Services and for Public Health. We'll start with DSS. This is as of August 31st, 2014. We're 16 2/3% through the fiscal year. So if you're looking on the screen, it's probably easier to see the areas with the graphs. So the first area is by area, and you'll see the black line represents 16 2/3% through the fiscal year. The mountain graph behind there, that's sort of a lighter color, represents where we were at this time last year. And then the bars represent where we are in our spending this time now, as of August 31st. And you'll see under contracts where we are above 16 2/3%. If you'll remember, that's because we contract with a lot of outside organizations that provide benefits for us, and that we have to prepay a lot of those expenses so that they'll have the cash flow in order to do their expenditures. And by accounting unit, or by the functions that we have within our budget, you'll see the only area where we're over the 16 2/3 is in administration. If you remember, if you've been here for a while, you remember that at the beginning of each year, the county charges us our full year's premiums for workers' compensation and for unemployment insurance. So that represents a full year's expenditures in the first 2 months. So as we go through the fiscal year, that will gradually decrease. As you'll see all the others, they're within the budget lines. Just to point out, CCS, that's Child Care Subsidy Administration. We contract those services out. We had not received a bill for payment, so that's why there's no 0% there, but the service is being provided, and they just hadn't billed us for it yet. Emergency assistance, the same thing. We are not yet fully into our emergency assistance programs that we contract with, mainly with Evelyn Foundation, Evelyn Charities, and ABCCM and Swananoa Valley Christian Ministries. Happy to answer any questions that you might have about the DSS expenditure report. Okay, then we'll move to the public health expenditure report, and it follows along the same lines that we talked about, particularly in terms of by accounting unit and looking at administration. You'll see that we're above the 16 2/3%, and it's exactly the same reasons, because we pay a full year's premiums for workers' compensation and for unemployment insurance. And just to let you know, that's based on a percentage of payroll, so that's why that number is so large at the beginning of the year. Otherwise, we're right within where we should be, and you'll see we're tracking along exactly where we were at this time last year. I'm happy to answer any questions that you might have on public health expenditures. Thank you, Mr. Chairman.
Thank you, Jim. Good as usual. Next, we have Gibbie. Are you going to lead us into our next group, if you would, please?
I'll get us started. What we have for you today is an opportunity to hear about and have some discussion about two different issues that are important to the health of our community. One of those is immunizations. We've talked to you about immunizations before and some of the issues we have in Buncombe County. We're going to give you an update on where we are with that, as well as have some conversation about some work that's being done to try to improve immunizations. I got everybody's attention up there. The second piece that we're going to do is on ACEs, and for some of you that might be the first time you've heard about this. It's ACEs, it's Adverse Childhood Experiences, and And what you'll learn is the direct impact that those experiences in early childhood have on the health of individuals as they age. We have a number of community partners here with us that are going to help us have these conversations. And Dr. Mullendor, our medical director, is going to lead us in the discussion around immunizations. And Neil Gregory, who is over our population health programs, is going to help us with facilitate the ACEs piece. So I'm going to turn this over to Dr. Mullendor.
Thanks, Gibbie. So like you said, I'm going to talk briefly about the state of immunizations locally, and then what we're also seeing in North Carolina and the United States as a whole. And then with the help of our Health and Human Services communication team, we're going to talk about what we're doing as an agency to address the issue that we're going to talk about. So the main issue is that immunization exemption is a growing problem in our county. This graph shows the number of kindergartners with vaccine exemptions in Buncombe County, beginning with the 1999 to 2000 school year through last school year. And as you can see, the numbers are increasing. And while the numbers of kindergartners in Buncombe County has varied over this time span, it's not the only factor that can explain this trend. There have been years where there are actually fewer kindergartners, but higher numbers of exemptions. And this shows the rates of religious exemption, or of religious exemptions in North Carolina and selected counties. So the scary line is the top line, and that's Buncombe County. This is kind of hard to see, but we are #1 in the state for the number of kindergartners who have religious exemptions. In North Carolina, there are 2 types of exemptions you can claim. One would be a medical exemption, so if a child has an allergy to a component of a vaccine or some medical condition that is a reason they can't safely take a vaccine, a doctor has to fill out, or a medical provider has to fill out a form and submit that to the state. The other form of exemption we have is called a religious exemption, and these are supposed to be true religious objections to vaccination, but these are not, there is no requirement for special paperwork or for validation by a religious leader. And our religious exemption rate last year was 4.3%, and that's 5 times higher than the North Carolina average, which is less than 1%. And this isn't just a Buncombe County problem. Of the 24 counties in North Carolina who have an exemption rate of 1% or higher, the western part of the state has 14 of those counties. We're the highest, or the region in the state that has the highest number of exemptions. And we know that, county lines don't keep diseases out. So this is a problem for a region, but a big problem in our county. And I've been asked before, so if, like 96% of the kindergartners are vaccinated, what's the big deal? Well, the problem is that, 1, it's a trend that's increasing, and 2, there is a point where herd immunity, that concept that if enough people are vaccinated, we can keep the diseases out and protect the most vulnerable, we're at that point where herd immunity is at risk. And this just kind of shows what happens when you start losing that herd immunity. So in 2010, we had 68 cases of pertussis in Buncombe County. That was our highest number to date so far. It's a pretty big outbreak. In 2013, the state of North Carolina had an outbreak of 23 cases of measles. And that was all triggered by an unvaccinated person traveling to India, coming back into a group of unvaccinated people, and spreading that way. And the big thing this year in the United States as a whole have been these huge outbreaks of measles and mumps. So as you see, as of late August of this year, 592 cases of measles and 965 cases of mumps in the United States. This is the highest number of measles cases since measles elimination was declared back in 2000 in the United States. Clearly, measles is not eliminated anymore. And the majority of the people who have gotten these measles and the mumps have been unvaccinated people. And so as of the end of August in Buncombe County, Here are our numbers of cases of vaccine-preventable diseases. So we've already had 33 cases of pertussis, 2 cases of meningitis caused by Neisseria, 13 cases of hepatitis B, and then earlier in the year we had 3 influenza deaths. And so given these rising numbers, given this knowledge of where we are as a county with our vaccine exemption rate, we know we're at a tipping point, we're a ticking time bomb, and we need to do something to change it. And the other thing you have to remember is that if the county kindergarten exemption rate is 4%, there are still these pockets. There are certain schools, there are certain classrooms, there are certain communities where that exemption rate might be even higher. And they're just, again, these are places where outbreaks can occur. And we know that. We know our disease control nurses, our school nurses know where those pockets are. And so what does the research show? So the research shows that parents look to their medical provider as their trusted source of information about immunizations. And just a 20-second conversation that a physician has with a parent can make the difference in that parent's choice to immunize. And so we, as our first effort in this campaign, we use this research and we use this as our focus. And so I'm going to turn it over to Stacey.
Thanks, Dr. Owen. Hi, everybody. I'm Stacey Wood. I work on the communications team here at Health and Human Services. And as Dr. Mullendor told you, we are facing a serious public health issue with our immunization exemption rate in our county. So, like she said, we know that parents get trusted information about immunizations from their medical provider. So we are focusing on the medical community at this point in this campaign. So our strategy is to, we want to focus on those people who are immunizing. We know that most people are choosing to immunize, so we want to raise the volume of their voices to change the conversation to the benefits of immunizations instead of the perceived risks around immunizations. We want to provide tools for healthcare providers so that they can have those conversations with patients. And we want those conversations to be efficient and productive. And we also want to educate children at a young age about immunizations, why they're important, because immunizations have done such a great job at keeping us alive and healthy. Kids and young adults don't have the context for why they matter and why they keep our community safe. So these are a couple of the things that the communication team was able to work on to help support this campaign. These are some of the tools that are being piloted in the clinical setting currently, and these are prompts along the way. So from the time a patient walks in the front door, they are encountering these prompts throughout their pathway to their provider. So bite-sized pieces of information, prompting questions, and then the button, the shoulder protection button that the provider, the healthcare professional wears that says, ask me if you have a question about immunizations, because we know that there's a lot of information in the world about what immunizations may or may not do. So we really, bottom line, want parents to ask their medical professional if they have a question. And on the back side of these materials, we have some tools to support medical professionals as they are having these conversations with their patients. These are adapted from some CDC materials, Ask, Acknowledge, Advise, and then the FAQs that the providers will typically encounter as they talk with parents about immunizations. And the fun part, this really fun part of the campaign is the part where we get to help children understand why this is important. So kids can write their name on a piece of, this immunization hero paper, and they can put it up on a wall where there are 50 other names of children who are a part of this shield of protection. And that really does create that sense of, well, I'm not alone in this. This is something that we're all doing. We're all doing our part to help protect our community. And the sticker, similar to I voted, it creates that sense of social responsibility around getting immunized. And hopefully, if we can catch them at a young age, they will carry that sense of responsibility with them throughout their lives. So at this point, the materials are being piloted in conjunction with a very cool partnership that MAHEC is able to help us with. And I'll let Frank Castellanco talk about the MAHEC piece and the exciting work that's happened so far.
So good afternoon. I'm Director of Continuing Education at MAHEC, and this has been an incredible partnership on a number of different scales. Number one, this really empowers a different group of people. It empowers children. Children are now involved in starting to be educated and starting to actually take a part in their own care and deciding, yes, I need to be immunized because this helps other kids. And I think that's really an important part of prevention. Going forward, we need to empower our residents. And the second part about it is really pulling in parents and educating them a little bit more and really talking about the true things that matter, because everybody has these perceptions of all of these things that can happen from immunizations that are incorrect. And so we started out with an event. It was exactly a month ago. It was Invisible Threat, and it was a very short film where we invited the community, providers, people from different practices, practice managers, and our own practices to come and listen to watch the movie and to listen to Dr. Mullendore and Dr. Mims and Deborah Gentry to discuss the very specifics of it and to talk about this campaign. And it was very well received. We had over 100 people come. And this was an event that we put on within a matter of a few weeks because we wanted to get this out there. And that's a big number to get that many providers from our community participating in this. And that was kicking off that pilot. How do we get more practices? And so we started thinking, and let's take it a step back. Before these kids are born, let's work on the parents and educating parents. And so we are now piloting in our Segnering Pregnancy Group in our OBGYN office the education materials. Because think about it, if you're pregnant, you're starting to consider, should I not? So if we can educate at that level, and the communications team has developed materials for that practice as well, and hopefully disseminate that, then you can go forward and really affect a lot of change. Another big part of it is there's a couple of practices that don't like paper, that don't like to hand out things. And so the electronic version of this is working really well, because they could send that out to their patients, they could send the materials out, they can put it on the TVs in their offices. So those components are great, and I think that that's what's going to make this successful, because it's different. It's thinking outside the box and not going through the normal pathway. And so, I value this relationship, and I hope to do a lot more things like this. So thank you, communications team and Health and Human Services, because I think this is going to be, hopefully, a step in changing these numbers eventually.
Well, and I'd just like to add, I was first sensitized to this issue last spring when Lisa Eby, through her communications committee, did a wonderful exercise on immunizations, and it was Sue Ellen Morrison, a staff member, who came to me and suggested that there might be a legislative remedy for this. It is just too easy to get an exemption right now. And the legislation that I proposed in the short session is really pretty common sense. It just says before you get an exemption, you have to have some kind of letter from a healthcare professional that says you have been explained the risks involved. And I was not successful at getting that passed during the short session, but I have had a conversation with Senator Apodaca, and Dr. Mims gave me some ammunition to use. She was once introduced on the floor of the Senate as Senator Apodaca's gynecologist. So I met with him recently, and I told him that I was talking to him. Right? That's right. I told him that, oh, I'm sorry, I forgot about that. But anyway, I told him that his doctor said that we need to do this, and I think he's very much open to the opportunity to help out with this issue. So thank you to staff for bringing that to my attention.
I'm just
See if you can up-top that list.
I am in trouble again.
So this is just one of those great projects that really highlights what core public health is and how we can use the resources across Health and Human Services and across our community in order to really affect change. And what's beautiful about this project is it's measurable change. So a year from now, we're going to know whether or not our efforts have been successful, or at least we're moving or inching forward on that goal. So it's extremely exciting. Our next steps, too, are also to engage the media in this effort. And Stacy's, just as she was very busy to get the whole invisible threat showing off and running with Frank, we're now looking to engage our media in Buncombe County, because one of the things that came out of that event was that the media oftentimes just show that side of immunizations, the scary side of immunizations, without understanding their potential responsibility and piece in helping to keep our community safe by showing that other part of it. So we're moving this out to the media. We'll do that in October. And as well as Stacy's reaching out to the individual practices beyond MAHEC. There were many other practices. I think we had 12 other practices or 14 that were represented there that signed up to say they wanted to be involved in this pilot. So it's all really exciting. And again, it just shows what we can do as we integrate efforts across Health and Human Services and across our community. We're doing things internally with our staff as well. So it's exciting stuff.
We'll transition unless there are further questions on immunizations. Well, as Gibbie said, I'm Neil Gregory, and I oversee the Population Health Division. I'm just going to change this PowerPoint out. And I have the distinct pleasure of also getting to oversee the Innovative Approaches Grant Project. Innovative Approaches is funded through the Division of Public Health, and this is a steering committee of community partners, an amazingly dedicated group that's focused on improving systems of care for children with special health care needs. And this group began looking at those things that are impacting our children and adverse childhood experiences, and the research that's been done around that struck a chord with all of us. And what we've done is create this subcommittee called the ACE Learning Collaborative, Adverse Childhood Experiences. And that learning collaborative, we have many of those members here today, and we're going to have some conversations with you. We have a table that's going to focus a conversation around health, education, around how adverse childhood experiences impacts us as individuals, and our emotional health or mental health. So thank you for humoring us and sitting at these tables and having assigned seating today. And I hope the noise doesn't get too loud, but we're going to first start off with a presentation by Dr. Adrienne Coopy. Dr. Coopy is a child psychiatrist with Mission Children's and Pope Stone, and a staff psychiatrist with Community Care of Western North Carolina. And before she starts, I also want to recognize Adrienne Gilbert. Adrienne is the Innovative Approaches Coordinator, who, bless her heart, can't be here today because she went to a wedding and ended up with emergency appendectomy in New Orleans. So she can't be here. But I'd also like to recognize Melissa Baker. Melissa started Innovative Approaches and has been sort of a driving force around the work we're doing around ACEs. So you'll have a facilitated conversation after Dr. Coopy talks to us about the research. And you have experts at each table that will just take a few minutes and tell the group how adverse childhood experiences impacts each of our sectors. And then we'd like to have conversations with you at the tables just about what's happening locally. So thank you, Dr. Gibbie. We appreciate it.
All right, so in less than 10 minutes, I'm going to talk to you about adverse childhood experiences, which I talk fast already, so slow me down if I need to. So what I really want to communicate today is how adverse childhood experiences cuts across all aspects of health and human services, and how a lot of the things that you all are already participating in and encouraging relates to adverse childhood experiences. This is your mission statement. And then how you can have adverse childhood experiences in mind as you're making decisions for the future of health and human services here in Buncombe County. So think of, I'm going to have a lot of keywords coming out today. So we're thinking adverse childhood experiences, or ACEs. We're going to talk toxic stress, trauma-informed care, intimate partner violence. So keep those in mind. This is the main pyramid. This is sort of like, this is the core of our conversation. And what I want to communicate today is how adverse childhood experiences, this is studied information, disrupt neural development, change social, emotional, and cognitive, cause that impairment, change the choices that we make, and then cause disease, impairment, and ultimately early death. And first I'm going to talk about the study that backs all this up. Actually has been replicated and is where it all really started. In 1985, Dr. Vince Phillip in California was working for Kaiser Permanente. He's a preventive medicine physician. And he had an obesity clinic, and it was really quite successful, right? So people were losing hundreds of pounds, and he felt good about this, but there were people dropping out. Like, they lost all this weight, and they dropped out of the study, and it was very frustrating to him, so he brought them back. He wanted to understand them, and he had the opportunity and time to do this. So he interviewed them, and he found out that these people had experienced adverse childhood events and had trauma in their early childhood. And it was a theme that he heard over and over again, especially in these people who didn't stay with the program. And so he really wanted to figure out why don't we know about this? Because in 1985, this was not a conversation we were having, right, about trauma. And so, so he got together with one of his colleagues, Anda, and they created 10 categories of adverse childhood experiences. And he's at Kaiser Permanente, and he was really quite fortunate. He had a large group of patients to pull from, and he was able to get 17,000 patients to participate in the study. And they interviewed them with the ACE interview, and these were all the questions, categories, not specific questions, but categories that they were asking about. And not only were they asking about that, the ultimate goal was to find out the relationship, right, between adverse childhood experiences and physical health that he'd seen in his obesity work. So he was interviewing them in all aspects of their life. This was just a part of it. He found in these 17,000 insured, mostly white middle-class Americans, that this was the amount of abuse that they had experienced in their childhood. This is from birth to 18 years of age. Now, we all know from our BRFA studies, and now 20 states, that this is happening everywhere. This is not this is being replicated, this exact information. Now, what they found out, or what they decided to do, was create an ACE score, okay? So, an ACE score is using these 10 categories to come up with your score. So, a person who's never had any of those abuses, right, has a score of 0. A person who was physically abused by their father all their life has a score of 1 if they didn't experience anything else in those categories. A person who was physically abused by their father, mother used alcohol, father ended up in prison, and was sexually assaulted when they were 16 would have a score of 4. Does that make sense? Okay, keep that in mind because we're going to talk about that later as we relate it to physical health. Adverse childhood experiences disrupted neurodevelopment. So we're going up this pyramid. The Harvard Center on the Developing Child has really brought a lot of information out about disrupted neurodevelopment and how toxic stress affects the child's brain architecture or hormone development and can do this chronically. So toxic stress, what is that? Stress is normal. We haven't had stress. Stress is good. It gets us going, gets us doing things. It helps us learn. But toxic stress, this is strong, frequent, prolonged activation of the body's stress management system. So stressful that you can't control. The child has no control. The big thing is they don't have an adult to help mitigate that, right? We have evidence, right, that an adult that can help support a child through that can help mitigate this toxic stress. But if not, we have changes. And we have changes in the way a child learns. So for example, we're being chased by a bear, okay? Doesn't happen often, could happen in Buncombe County, but it doesn't happen. But you're being chased by a bear, your eyes dilate, so you can get all that light in so you can see. your blood rushes to your arms and your legs so you can run. The part of your brain, the prefrontal cortex that's ready to do math problems, it's not on, you don't need that, you're not making any decisions, you're running, right? So a child who's constantly in this toxic stress environment, this fight or flight, their prefrontal cortex is off, okay? So they're not ready to learn. Those children with greater than 3 ACEs are 30 times more likely to have learning behavior problems. They're not ready to learn, they can't concentrate, right? And so David Thompson's going to talk a little bit about what we are doing in Buncombe County and some of the things that have been done in Washington State, namely the compassionate schoolings programs. So schools that are trauma informed, who understand that kids in this state can't learn, but we can help them. Just really quick, intergenerational transmission. So in the media today, right, we have a football star who harmed his child, but what did he experience as a child? His ACE score was at least a 4 from what we know, right? His father was in prison, was physically abused by his stepfather, and watched his, I mean, he had quite a few ACEs, right? So there's intergenerational transmission of ACE scores. Intimate partner violence, again, an intergenerational and an environmental sort of transmission. So people who've experienced more ACEs are going to be more likely to batter or be battered. Pyramid. So we talked about disrupted neurodevelopment, talked about some social, emotional, and cognitive impairments that are caused. So adoption of health risk behaviors. You have a child who's having adverse childhood experiences. They're having difficulty learning. They're not doing well in school. They're falling behind. They're making probably relationships with peers that are similarly having similar experiences. They're not able to relate to adults and make those really positive experiences. They start making choices in life to make themselves feel better. They may be using drugs, smoking, not staying engaged. Those choices that they're making are a solution for them, right? So if we're trauma-informed, we understand that those choices, smoking, drinking, using drugs, are making them feel better, right? It's not a problem to them. This is their solution. So don't stop smoking, it's bad for you, isn't really going to help them because that's making them feel better. So this mind shift is some of the things that came out of the study. Okay, this I'm going to go through really fast, but it's a lot of slides that show very similar things about different subjects. On the bottom of all of them, you have an ACE score, and it goes up. And on this side is the percent of people using or doing whatever. So as ACE score increases, IV drug use increases. As ACE scores increase, adult alcoholism increases. ACE score, smoking. So these are all adoption of health risk behaviors, right? ACE score increasing, sexual partners or greater than 50 sexual partners increases. So we saw, so this is all in the original ACE study. These are the numbers. So as a result of adoption of health risk behaviors, disease, disability, and social problems increase, right? So ACE score increases, suicide risk increases. ACE score increases, depression. Now some of these sort of mental health ones, I was like, okay, that makes a lot of sense, right? So heart disease increases. And there's been more and more information about inflammation in our bodies and having this toxic stress. It changes our inflammation rate and makes it more apt to have physical health diseases. So this is a slide that's got increase in ischemic heart disease, stroke, chronic bronchitis, diabetes, hepatitis. And this is so I don't know if you remember from statistics, population attributable risk, but this is a really neat one that talks about the proportion of the disease that is due to ACEs, okay? And this is a great slide I got off of ACEs Too High, which is a website. Okay, so you see in the middle, it's not the black, and that's ACEs. So let's say, for instance, we're going to choose at the very top, alcohol, heavy drinking. So of all persons using alcohol and heavy drinking, 21.3% is due to ACEs. Let's go down right below that, and that other white line. Mental health condition disturbing days of work or activity. 61.4% of that can be attributed to adverse childhood experiences. I mean, anxiety, mental health, hopelessness. 67.2% of life dissatisfaction can be attributed to adverse childhood experiences. And this being, I think, kind of a hard one to even say, but people with 6 or more ACEs die 20 years earlier. This is what they saw, 17,000 people. Those with 6 or more ACEs were dying 20 years earlier than the average of person without ACE. I did find an economic burden study and from Prevent Child Abuse, and it's just, you know, persons with adverse childhood experiences generally aren't able to contribute to the workforce as well as those who don't, and end up costing our system more. So in Buncombe County, we are doing some really, really neat things, and I'm so excited that I get to be a part of that. The ACE Collaborative is working with Dr. Koa and some other primary care providers to do some piloting of ACE questionnaires. We have an ACE primary care resource guide that talks about ACEs and sort of how you present that information and the importance of that, of ACEs in our community. We're talking, or we're creating a speakers bureau because we really need to, get this information out. I think it's the root of everything. So I'm ready to talk about it anytime because I really find it to be unbelievably important. We do have a website, buncombeaces.org, which we're constantly updating and adding information to. And then the Buncombe County Asheville City Schools $1.2 million grant that I hope that you're going to give.
We're going to talk a little bit about it.
Great. And I'm so psyched I did that so fast.
Actually, it was a grant for Buncombe County. We're just including the city because it's the right thing to do.
It is the right thing to do. Just some things you can read. And so,
Yes, we're going to do.
I'll have to write down all this website.
so I guess you each have a mediator. Do you want to? Or,
I can.
oh, it's okay.
Okay. So now we're going to just start having some conversations. We're going to start with each sort of one of our ACE collaborative members from each table standing up and just talking about how adverse childhood experiences are impacting their sector.
I was going to say something before we did that.
Yeah.
There's a growing body of literature. I think some of you know I'm sort of tunnel visioned around race and ethnicity. But there is a large body of literature currently on neobiology, and it all points to adverse racial stresses as equivalent to those. And I'm sort of disappointed that we don't have those other than the intact family dynamics represented. But things like poverty are also adverse effects that may not have anything to do with the violence that I saw there. And simply being a member of a racial ethnic group is an adverse childhood experience and also an adverse adult experience.
Right. And that's, as Dr. Gibbie said, the study was done, this large study was done on, just middle class
Sure.
insured individuals. And it has been, North Carolina has done, the ACE study has added that to the BRFAS, which is a survey, a telephone survey, and so we have results for North Carolina that you can break down by race. So we can get that information to you as well to show some of the differences.
And those aren't all the adverse childhood experiences you possibly have.
That's right.
Those are the 10 that were in the study. We showed that correlation. So we know there are plenty more. And thank you for adding that.
So part of the ACE Learning Collaborative, we've sort of developed our trails for how are we organizing this. And I know you can't see it that well up on the screen, but we're going to let Dr. Koa start with talking about how adverse childhood experiences impacts his work as a pediatrician.
I'm Joel Koa, primary care pediatrician with Blue Stack Pediatrics. Due to limited time in the English major, please forgive me, I'm going to oversimplify. We're at a great transition point from primary care. A long time ago when medical care started, people came in with bad stuff and we tried to do good stuff to make the bad stuff better. As medical care has progressed, today we do a lot of screenings to try to identify bad stuff sooner and try to give treatment sooner and redirect individuals to hopefully prevent further complications. We're at a point now where we can take the unbelievable step, I think, and prevent disease from occurring. We saw, for example, just now, heart disease. Maybe we can prevent heart disease from occurring by how we raise our kids, how we set up our community. So this is an exciting time right now for us to be in transforming that care. ACEs, when you talk with about kids, adverse childhood experiences, you think, where do they get those experiences from? Well, they get those experiences from adults, so let's just go right to the adults and tell them to change their ways. Well, thank you. Okay. So when you start to talk to these adults, they look at you like, well, this is the way it is. It's always been that way. It's always been that way. And so they have this hopelessness about them when you start talking about ACEs and how it affects the adults. So having it move into the child world is reasonable. Example, my kids started in school, and that was the popular wave of teaching the kids about recycling. All these kids went home and beat their parents over the head about recycling. And that's how we change our community. And so the schools are going to offer that opportunity. We need to take it even a step further. These adverse childhood experiences start even before the school years. And so there's exciting things that Buncombe County is supporting, like Triple P, the Positive Parenting Program. And that's going to help transform how we care for our community and our kids. It's going to be a community of care. Physicians can't do this by themselves. We need the community support. And that's one thing as we're talking about how we're screening families, kids, identifying these concerns. How is the community going to support this? Because a physician can't go and live with these families to change how they're doing things. So we can be part of the team, but Buncombe County, we hope, will support these teams.
Thank you, Dr. Coa. And now we're going to let Amy Griffith give us a little bit of how this impacts the emotional and behavioral health side of things. Amy is the Director of Forensic Services at RITA.
Just in a nutshell, I think everybody can see that these are the kind of people that end up receiving or needing mental health substance use services, right? So on the back end of this, there's all this really great prevention stuff, but on the treatment end, clinicians need to be more trauma informed because much like physicians, it's not just treating a symptom, it's looking at that whole piece and where that came from. But I think also what's important for this group to realize is that these are the people, the ones that do end up needing these services that are costing this county the most money. They're in our jails, their kids are in custody, they're cycling in and out of inpatient and ED settings. On that extreme end, we need to create a trauma-informed system that interfaces with them on all those levels. This table is going to have a great discussion about how much child protection is doing around trauma-informed services. It's pretty neat to see that happening. We're doing it in the jail. We're teaching the ACEs study in our crisis intervention team training with law enforcement now. I'm having conversations with judges, not only in family court settings, but in other drug treatment court settings about being trauma-informed and aware of how much these things are impacting the people that are moving through all of those different systems. So.
Or can Mary Lynn? Yeah. And now we'll let Mary Lynn Barrett, Mary Lynn's Director of Behavioral Health Services at MAHEC. And again, this is the community. I didn't know the order of the slides, but sort of how adverse childhood experience impacts us as individuals and then what we can do about it as a community. Mary Lynn?
So there's a lot of really good websites about ACEs, and I was on one recently, and there was an article about a community in Florida, I don't think it was Tampa, somewhere else, but that had proclaimed themselves the first trauma-informed county, I think, in the States. And I thought, well, that's interesting, that's cool. Hey, but wouldn't it be cool, wouldn't it be even cooler to be the first resiliency-informed county in the United States? Because I think what resiliency does is it's further upstream from trauma. It has the capacity not to teach resiliency skills to somebody that we know has already had a trauma, but we can go upstream and teach resiliency skills to everyone. So that when the traumas that happen to everyone, it's across the board. It's not all, there's more things that disrupt our nervous system than what we saw in this study, but so that everybody has the skills to deal with these traumas. And so one of the things we've been doing with the community resiliency model, which is what I train in, and helps us understand like how we're affected biologically in our nervous systems by stress is to get the model out to the people. We're not limiting it to mental health practitioners. We're not limiting it to any kind of professional. In fact, we're trying to get people who are not necessarily in that group to come to our trainings. Either trainings just to learn the skills for themselves and maybe to use on their family or friends, but also we do these skills train the trainer program, which has been really wildly successful. In fact, you are surrounded by trainers. You may not know that. You are surrounded by resiliency trainers at this moment. And they have already trained over 300 people in this model, and it's all about resetting the nervous system, which when we looked at the pyramid, what happens from adverse childhood experiences or adversity in general, and especially in childhood, is that stress response gets turned on. And if it does not turn off, then it causes all those things down the road, whether it's the first thing is that just unhealthy coping mechanisms, and then maybe eventually it leads to the diseases that we saw in the mental health problems. But so learning how to turn that off, or having the skills to turn that off, is the resilience. It provides the ability to bounce back. So that's what we're promoting.
And then David Thompson is Director of Student Support Services for Buncombe County Schools, and he'll give us a quick look at how this impacts our education system.
Thank you. Ask any teacher, any principal that you know, and they will tell you that they are seeing not only an increase in the number of students who are presenting with extreme behaviors and mental health issues in the schools, but also that the age of those students is younger than it ever has been, and that the severity of those behaviors is increasing over the years. My point is, and I think that what we have learned from ACEs is that that is the result of childhood trauma and toxic stress that happens at a very early age. I brought a few numbers for you just because I'm a data person. I'm an old school psychologist and data nerd. And so I like numbers, I like data because they speak louder than my words. I told you last time that in a 36-week school year, we probably did 2 grade assessments a week. Well, the number was actually 287 over a 36-week last year. So that's really more like 7 or 8 per week. I mean, really specific threats. We did well over 1,000 functional behavioral assessments due only to classroom presented extreme behaviors to develop behavior plans. We had about 1,500 students on very specific safety plans that were due to things like sexualized behavior or other very specific behaviors that are threatening within the school environment. And probably the most shocking, we did about 200 suicide assessments last year on our students. 25 of those were elementary school students. So the impact of adverse childhood experiences is, the numbers are more powerful than my words. Yeah, I was sitting in a conference yesterday, a this week experience of a child who, as I counted just from the conversation, has an ACE score of 5. He's 5 years old. Yeah, he's 5, and his behaviors are just really off the chain. And the teacher says, well, when I tell him these things, and he won't do it. So the answer to this, and I pointed out, but he really can't process what we're saying when he's at that state. The answer is not getting him to change his behavior. We change what we do. We can help him. We can help him learn how to return to that self-regulation by what we do and not by what he does.
Okay. So now, excuse the noise, but we're going to engage you in a conversation. You've got a facilitator at your table that's going to have a conversation with you about what's happening locally and what else can we do.
Also, right in the same time, and I'm going to help us talk louder. The first part is what you all thought was happening throughout our community is helping us to prevent or reduce negative consequences. What are some of the positives?
A little bit about what we're seeing.
school nursing, I was going to start out with the numbers too. We have this year so far in what we've discovered, out of the 35,000 altogether, both district schools, 7,000, over 7,000 special health students. So that just talks to the physical and mental health issues. So our nurses, we have done resiliency training with our nurses, they're all trained, and continue to be working on those things. And then helping human services, even if they're not teaching, so that is progressing out and along many different levels. I know some of the folks from the NFP have had that training. Several nurses
related to that, what you have been sort of spearheading. You have also had work with that's really good.
The trim training we just did? Yeah, so we just did it with Mary Lynn and Dawn and anyone else people right here. Where we had, did offer a free 8-hour training to community members. It was open to anyone in the community for free. We actually targeted outreach into mainly minority multicultural populations because we don't have a lot of people of color in the mental health profession. So those individuals often don't feel comfortable getting mental health services, don't feel comfortable getting mental health services. So these are skills that people can use to reset and dysregulate the nervous system that are easy, that you can use anytime, any day. So we actually had closed registration. We had 1.75 people registered for it. We probably had around 55 that actually showed up, I think. And then we'll go on from there and continue to just ripple that out into the community. We're also doing things, and that was a concerted effort across many. It was people that have been trained across the community coming together and donating their time to that effort. So that was really cool. But we're also doing really great things with our staff and really trying to bring resiliency back into the workforce in a way that's really helping the staff to be able to recognize cumulative trauma based on what they're seeing every day, based on the jobs that they've done. So trying to get those skills and practices within our workforce that creates that resilient community that we're trying to talk about is really important. And then just the last thing of that is I'm doing a lot of research on just on how the physiology of how our brains are social brains, and that socialness of our brains. We think of our brains as this thinking mass, but it's really about social relationships. And it's not treated as a threat or as a reward. It's a threat or as a reward. We engage at work in that process constantly. Is my boss saying something negative to me, or is my boss saying something good to me, that I just get praised and take it down a notch. And there's this whole field of research about that. And so I want to use those same tools and concepts so that we create management practices that really create a safety in the workplace where people don't have that threat in their work. And that is another part of racism. Color and non-minority versus population feel that threat in two ways. So get that ingrained in our teaching. That's what we're doing. Where did you want it? So like the ones we're talking about, the wellness skills? Right. Just look at this right now. Just sit comfortably in your chair. Maybe put your hands on the table for a second. Well, you sit however you want to sit. You sit however comfortable you want. But I wanted you just, I was going to let you see because it was quick. And for me, I talk now with my hands on the table, and you want to do that for me because it works for me. It might not work for you. I like the coolness of the table because it's calming to me. Because I run very hot and fiery. And the coolness of the table is a way of grounding myself in a way that keeps my nervous system in check. You might not like that. You might prefer the fact that you're slouched back and that you feel the safety of a chair, but it's all about connecting in ways that allows you to feel present, supported. That's one tool in the grounding exercise. We don't have to go through.
It's a set of 6 different wellness skills. Okay. And the way in which I think it really diverges from what we've tried in mental health in the past historically is that we've always engaged around trauma or stress by either asking people to think about what's going on for them or to change their feelings. And this is about recognizing that neither thoughts nor feelings and emotions are going to actually bring us a shift, that noticing sensation and the pattern. So it's real divergent in that way. What's so cool is you don't have to have a therapist or be a therapist or trauma
when we work to help prevent, really the goal is to help prevent abuse from happening. And so, why I think it's important that you all know about that model is because it's a non-mandated service area, which means that, you know, the county is not going to fund that program that doesn't necessarily have to be funded. But you see the long-term importance of funding a program like prevention, because then you have those other negative outcomes that you do pay for in the long run. So my hope is that, you know, even prevention social work we can use, and I've been trained in the CRAM model, but it was a shorter version of the resiliency model that Mary was talking about, Suzanne was talking about.
How do we engage?
So, if we have folks who are out there in the community, social workers, also supporting families, I think it's so important that as a whole it will help us to be a healthy county. And to help us to avoid some of those more costly services and outcomes. So I hope that the value of prevention social work is one that the board will
We still hold true to the
so that we
bottom
can
line.
maintain funding. It's not difficult to fund it, because the Medicaid rules have changed. And we're looking at a whole different model of billing for it. It's difficult to do. So that's prevention. If you have any more questions about it, I'll
And then a lot of it's around how you cast vision.
No, I was moving that way.
Wonderful. Yeah. Future. So really, instead of telling people what not to do, traditional bills done in the child protection, really helping cast vision for what we'd like to see that's different. But that's a much different conversation than telling people.
Really a toolkit.
There's lots that goes into it, but that's a lot
From
of it.
seminars on all the way to very brief ways of engaging parents. So prevention social workers trained in positive parenting programs can use these tools naturally within their workday. We're training, you know, folks in pediatricians' offices, we're training care coordinators, we're training folks all in mental health therapists. And this goes all the way up to high level for the child. Ways of promoting so that based on this resilience, because you see people that are at and getting the tools they need through effective strategies. So it can be anything from helping someone manage the challenges of, you know, bedwetting, all the way up to severe oppositional decline of now we're hanging into, we're working to sort of move into getting some folks trained at the judicial system. We have RHA has staff working on this their services. Again, linking, you know, with the work that social work is doing on trauma informed practice. Y'all, the board has heard that before, where the social workers for child services do trauma informed practice. This is another tool to support that type of work. So all of this needs to work in a way that supports a resilient community. Another program that you evidence-based expertly is that we provide can help them with nursing partnership. And that's we show that home visiting graduate nurses federal funding out which is great, because again, you're trying to break that cycle early, and you know that the sooner you can go, you know, before that baby's born, and we're becoming really sound, and I have a pregnancy ideal.
And so, the other thing that's really important to remember about all this work today, as a health community, working with other members in the community, is that this is about biology, and that it's really a different shift, so that when a teacher sees a child that's acting out wildly, their first thing is to do like a behavioral remedy, but it's look at that from understanding it's got an etiology and deep core brain processes, and that the remedy, the solution, the way out is not through that way. So if you're looking at disciplinary, like 62% of absences or verbal
both elected officials and institutional leaders. So, and we need to do it together. Yeah, well, we'll be back in touch with you about that. Great.
And that's where that.
I think the important thing, when you look at this literature, it's so, it can be very depressing, honestly, especially for those people that have high ACE scores. It's like, oh, yay, 20 years going on, thanks for that, appreciate it. But what we know also is that all these protection factors out there, and there's a lot of research on what
they find that they can create their own way of working.
All kids are learning. One of the things is that
How to safety.
kids who don't need it, perhaps.
It was interesting, Tara, when we did this training, the community advisory group, and actually started with Melissa, did it, and we did the training, but when Melissa first came and started talking about toxic stress, like, we have a lot of people of color in that group, and they were like, oh, thank you, that explains it, you're not crazy, you know, thank you, and it was just like you could see the
Destigmatizing.
well, it was destigmatizing, but thank you for putting a name to what I know exists inside of me that I've never been able to name, and I carry it around and I play on it every day of my life, and it was like, it was really powerful.
Probably not.
In our training last Friday that we
So
did.
we have to admit that there is an issue.
All of our navigators, Health and Human Services.
I learned that when I was in
So they'll now be taking in that.
I have an African American parent who wouldn't say anything.
So one of the hopeful stories I have out of the nurturing the infant brain experience is that a colleague of mine has been deeply moved by understanding ACEs and her she's been working with infants and toddlers for 25 years and has a master's degree. Excellent what she does. And she's also reportedly admitted a difficult person to use ACEs. She's great with her clients, she's hard on them. And she's studied for a realization for parents early on. I want to teach you guys how to read about what ACEs is. Understand what my ACE story is. You will understand more about what's in my life. And Kate said, in 22 years of working for the state, I have never been to a 2-hour luncheon line that was as powerful and amazing. People were and her point was to have compassion for self and others and understand where this is coming from instead of just judging one more time. Unlike being our client or ourselves, we can actually move past that and go, wow. And her thought was, you know, I don't feel guilty about it. She had that same thank you experience. She had the same communication. She said, thank you for an ACE story to make sense for me of why I feel so good and how I lash out at ways that I don't know. And she's using that to make but to offer that as a professional opportunity for deeper self-awareness within it, make you a role was one of the more powerful things I've ever seen happen. State training. What are some of the aha moments that some people out of that? Okay, you might want to wrap everybody up.
If y'all want to be the first one to figure out your aha.
I think she's going to offer us a chance to see has there been an aha moment for us to get here or something? You don't stop and tell us. Take a few minutes. Share a couple things. Well, I read a few notes on section 1 was the safety question.
If you have one item that you're all can think about it, but we'll wrap up. Thank you, everybody. We're going to need to wrap up our conversations today. Do we have a couple of... I'm sorry, I'm going to have to stop our conversation. If everybody can just take a Did anybody ever hear y'all recording it? Y'all want to share an aha moment? Let us know.
Well, I mean, I'll share the ones that I heard just from the discussion. I heard Child Protective Services talking about using elements of TFCBT with children.
TFCBT?
Oh, trauma-focused cognitive behavioral therapy. And watching parents hear and see things with their children that were aha moments to them about their role in preventing further trauma or ACEs for their kids. And then we were talking about the community resiliency model, and I think that we have a volunteer to bring it into the jails and help teach some of those resiliency skills to some of our fitness folks. So those are my two big ones. We have a volunteer now.
One more aha, anybody?
We had one that I thought was, I still think is good. We've got to get this in the curriculum of the school.
Absolutely.
We talk about all of the social workers and all of the counselors doing it. It's not enough. We've got to get it taught to every kid.
Yep.
Every kid in elementary and middle school.
And thank you, that's a great segue. There are little cards on the table if you want more information about adverse childhood experiences. The ACEs connection. There's also a small little business card, maybe.
Well, they're in there.
Yeah. There's our Buncombe ACEs website, and ACEs, and that has a compassionate school curriculum on there, Don, that you may enjoy. Thank you all. We appreciate your engaged conversations. If you want to know more, please let me know, and we'll certainly share the PowerPoint with you.
I want to say thank you to everybody that joined us and participated today. To both Dr. McElrath and Nell, they did a great job putting this all together. We, as is our MO, have done all the interesting, let's move us ahead, innovative stuff, and have a little bit of business wrap up. Invite our guests to stay with us, but if they want to sneak out, we will not. In any way, feel bad that they don't want to hear Gibbie talk about accreditation policy. But we're going to let Gibbie start, Phillip, just because she's got policies she has to get approved if she's doing those, or if somebody else on health staff is doing them, or Don's doing them, Dr. Locke's doing them.
So I'm just going to remind the board, we will be making flu shots available to you right before the October board meeting. So if you come in at 11:30 like you normally do for lunch, we'll also shoot you in the arm. All we have to do is get you to sign a form saying it's okay for us to do it. So just be ready for that when you come. And we do have the quadrivalent, the one that has the 4 doses in it, that will be available for you. So, and Don will do the honors around it.
Well, I want a personal privilege, Mr. Chair. When I learned that we were going to have 3 flu shots in October, I will not be in the October board meeting. So I said to Gibbie, what can I do? She said, you can go up to the health department right now. So I went over to the health department and I went through as a regular patient. And I want you to know it works. And when I got the little sheet, I checked off were people kind and cordial or whatever it says. I said, yes, and I handed it to the woman. She said, oh, really? I said, yeah, y'all are really nice over here. Well, guess what? I went to get 1 shot. I got 3. They lie about putting it all in 1 needle. They don't. I got because I got the influenza, and then there's a new pneumonia shot that people over 65 are recommended to get.
What you get when you're old.
They still give it to you.
I'm gonna get you for that. And I also had what happened was she called my doctor for some reason to make sure, and she said you also need an update on the TAD. So I got 3 shots, and I want you to know, man, it was very efficient, and I really appreciate it. And this is what we ought to have them filming and broadcasting, is this kind of meeting, because I'm excited today about what we talked about.
It is filmed.
Is it? I'm excited about this, and one of the things I'm excited about is that I live in Buncombe County, and I don't care if the immunizations, lack of immunizations is high. There are reasons for us to be very proud, and I think we all are proud of our Department of Health and Human Services, so I'm going to start my sermon right now. Mr. Chair, the Public Health Advisory Council is recommending the following policies for approval. They were sent out to you in your email attachment: the Workforce Development and Orientation Policy, the Hiring and Retaining Policy, the Performance Appraisal Process, the Community Involvement in Public Health, and Community Education Outreach Policy. They're really minor technical changes. There's nothing substantive, but the Public Health Advisory Council has approved them, and I bring them to you as a recommendation for your approval.
Or you make that as a motion?
Yes.
Do I have a second?
Second.
Moved and second.
like to remind you that we are having a little party today, a little celebration for the Culture of Health Prize at 4 p.m. at the Wilma Sherrill Center on the campus of the University of North Carolina, Asheville. All of you will be there to see some of the Robert Wood Johnson folks and to share in our celebration. An important thing to remember is the Culture of Health Prize didn't say we had done what we ought to do. It says we're on the pathway to a community of health. And we have in place the resources, the people, the processes to get there. That's the important thing. We have a lot of work to do, as we hear in these presentations today, but we have the people, we have the processes, and we have the prospect of getting there. So it's important for us to celebrate that in Buncombe County. Thank you. Thank you.
Phillip, Angie, anything you need to cover today? I know your worlds are jam-packed too, but I did just want to take the very last few minutes to ask those employees who are leaving us because of early retirement to please stand up so we can recognize your work. I know. Pioneer work in moving from the delivery of services to helping us build systems that help us make good management decisions and good resource allocation. And we can't thank you enough for the foundation that you laid. And the T-Timble are shoes we just flat will not fill, and that's just the absolute truth of it. To the extent that her job will be 2 jobs. When she leaves, always the highest compliment is that. But I can't, thank you enough. You hung in there and led through a lot of transition and a lot of change, and always kept just what Dr. Locke said, the patient and the public first and foremost. My sincere appreciation to all of y'all for what you've given to the organization and the community. Enjoy your retirement and come back. We're here, as y'all know, every month. We're going to let y'all go because I think we're pretty much out of time.
All those that want to adjourn, you may get up and leave.
All in favor?